Now, appetite is influenced by many factors that are integrated by the brain, most importantly within the hypothalamus, as we have already discussed. Signals that impinge on the hypothalamic center include the neural afferent, hormonal, and metabolite signals. There are signals from the metabolic system. The signals are also coming from the hormonal system. Signals are also coming from the neural afferent on the hypothalamus to increase or decrease the appetite. The vagal inputs are particularly very important. Vagal nerve plays a very important role. This vagal nerve is also a connection between the neurological CNS and as well as gut brain. Okay, gut is mainly related with the digestion, metabolism, etc. We know that. So vagal inputs are particularly important, bringing the information from the viscera such as gut distension, etc. Hormonal signals includes the leptin, insulin, cortisol, and gut peptides. Among the latter, the ghrelin, which is made in the stomach and stimulate the feeding, and peptides, YY, and cholecystokinin, which is made in the small intestine and signals to the brain through the direct action on hypothalamic control centers or via the vagus nerve. Now this ghrelin, okay, hormone, so that is very important. It plays a very important role in appetite. Okay, it actually carries the signals from the gut area to the brain. Now metabolites including glucose can influence the appetite, as seen by the effect of hypoglycemia on inducing hunger. However, glucose is not normally a major regulator of the appetite. So glucose is not related majorly with the appetite regularization. Okay, of course, whenever there is a hypoglycemia, it induces it induces the hunger. We know that. But however, the glucose is not a big factor in appetite control. Now these diverse hormonal, metabolic and neural signals acts by influencing the expression and release of various hypothalamic peptides, like example neuropeptides Y, agouti related peptides AGRPT, alpha melanocyte stimulating hormone and melanin concentrating hormone that are integrated with the serotonergic, catecholaminergic and endocannabinoids and opioid signaling pathways. Psychological and cultural factors also play a role in the final expression of the appetite. We know that. Apart from the rare genetic syndromes involving the leptin, its receptor and the melanocortin system, specific defects in this complex appetite control network that influence the common cases of obesity are not well defined. Anorexia means it is a strong disinclination to eat much food even when there is no physical barrier for eating. This is what exactly Ayurveda is also saying. Prakshiptam tu mukecha annam ruchim na utpadayanti iti bhaktadvesha. Now, pathway of hunger and appetite. While on long-term regulation will takes the cues from the body fat. Low fat content in the body always encourages the feeding and energy preservation. This is a body physiology. While high body fat suppresses the appetite and promote the energy expenditure. There is involvement of two important hormones. Number one is leptin and another one is insulin. Insulin is produced from the pancreas and it is released into bloodstream upon food ingestion and when the blood glucose starts raising. While action of the leptin is different. Action of the leptin, it is a hormone secreted by the adipose tissue in the process of a process which is independent of insulin. So insulin is related to glucose and all those things, but production of the leptin is independent of this insulin level and it is produced from the adipose tissue. Now what is the pathway of the hunger? The amount of the circulating plasma leptin is directly proportional to the body fat content. increased leptin levels in the blood, suppose if there is increased leptin levels in the blood, it signals to the brain that body has enough energy and it has to stop eating and start burning more energy. Leptin and the insulin seems to work together. They are not interrelated. That means they are not interrelated, but they work together on the hypothalamic nuclei as other brain areas to inhibit the other brain areas and increase the energy expenditure. Obesity results from the deregulation of the feeding behaviors and energy metabolism. We know that. Obesity is commonly associated with the chronic low levels of the leptin activities. If the leptin activity is normal in your body, then that itself gives a stimulation that now stop eating, stop taking fatty contents. This is a time of burning the calories. But suppose if there is less amount of leptin in the body, okay, so then itself is one of the cause for the obesity, which tricks the brain into thinking the body that always starved. This leads to overeating and excess energy storage as fats. Now, obesity is commonly associated with the chronic low levels of the leptin activities. Because of this chronic leptin activity, what happens? It stimulates the brain thinking that body has got a less fat. If the leptin levels are normally maintained, it suggests that body has got normal fat and it is receiving the signals. If it is low, then what happens? The brain thinks that okay, leptin levels are low, that means that body fat is low. So now what happens? It leads to overeating and also excess energy storage in the form of the fat. Continuing the pathway of the hunger, both genetic and lifestyle factors contribute to low leptin levels in the blood. But contribution of each factor varies significantly from person to person. The major lifestyle factors is energy-rich high-fat diet. In the early stage of the high-fat induced obesity, increased amount of saturated fatty acids. These increased saturated fatty acids will cross the blood-brain barrier and provoke an inflammatory response in the hypothalamic neurons. We have to look at the hormonal level in the blood. Hypothalamus is the area which determines that does we are hungry or not. It makes the distinction that body is rich in energy or poor in energy. After eating, when our stomach is full, then the insulin is released and it will go into block the hypothalamus secretions, which are responsible for decreased appetite and we feel satiety. When we take the fatty food, it will release the hormone called as leptin. When we take the fatty food, it will release a hormone called as leptin. Presence of this enzyme, rather it's called as an enzyme, it's not a hormone, sorry. Okay, so presence of this enzyme will represent the energy rich nutrient in the bloodstream, and again this signal also goes to hypothalamus and binds with the receptors there to inhibit the hunger. Now chronic low levels of leptin will cause a problem, but the leptin level rarely changes because if we eat fatty materials, it will be stored in the adipose tissues and not available in the bloodstream to sense the hypothalamus. After eating, stomach will be full, distended. Then another enzyme called as ghrelin is released. It will go into inhibit the hypothalamic factor responsible for hunger. And there is a theory of Erikson's theory of psychological development in infancy. Of course, this is not related to this. Okay, now what are the pathological causes of anorexia? Anemia is one of the most common cause. Okay, there will be irritability also, especially in the female kids. Other causes are infections, acute viral or chronic infections, tuberculosis, lessened body metabolism like hypothyroidism, avitaminosis like conditions like B complex deficiencies, endocrinopathies, liver disorders, renal disorders, CCF, congestive cardiac failure, certain drugs like amphetamine, digitalis, some of the antibiotics which alters the flora, malignancy, yes, gradually developing loss of appetite is maybe the symptom of malignancy like leukemia, lymphoma, etc. Then neurosis like psychosis and anorexia nervosa, metabolic disorders and chronic disorders and anorexia nervosa. Some of the other causes related to pathological causes of anorexia are improper weaning technique, especially in children. If the child is having temper tantrum, use of pacifiers, pharyngitis, evolving hepatitis, as constitutional symptom of certain chronic disorders. Okay, in certain chronic disorders like tuberculosis, etc. As a constitutional symptom, the loss of appetite will be there. Worm infestation, okay, gastrointestinal reflux disorders, the big list is there. But some of the rare organic causes of loss of appetite, if you see, silver result syndrome, where there will be poor appetite, fizziness, triangular face, slow feeding and other problems related to oromotor feeding, Noonan syndrome, duodenal web and congenital melanin myopathy. So this is if you want to see DSM-4 criteria for the diagnosis of loss of appetite in children. Persistent failure to eat adequately with a significant weight loss for at least 1 month, not due to primary GAT problems or other general medical conditions like GERD, not accounted for by another developmental disorders, example rumination disorder, etc., onset before the age of 6 years. So these are the criteria given in DSM-4 for diagnosis of loss of appetite in the early infant or childhood. These are some of the important red flags to identify: history of dysphagia, odynophagia, incoordinated swallowing, feeding interrupted by crying, frequent ear infections, vomiting or diarrhea, recurrent pneumonia or the pathway disease, failure to thrive, growth chart flattering, red flags. Detailed head and foot examination has to be done. Systemic examination has to be done. Try to identify the red flag signs: edema, icterus, respiratory distress, clubbing, cyanosis, lymphadenopathy, etc., etc. We may need to the specific investigations also. Like CBC gives maximum information many times, urine microscopy, a renal function test, liver function test, specific investigation if at all it is required. What could be the other issues for loss of appetite? Maybe palatopharyngeal incoordination, autism spectrum disorders. In the autism, again, that's the problem with the sensation. Sensory block will be there, so child may not able to appreciate the taste of the food. Then hypothyroidism, yes, long-standing foreign body in the upper GIT may be also cause. Chronic kidney disease, very important, tuberculosis and occult malignancy. What is the method of inquiry? Yes, history of emotional upset and neurosis has to be asked, fever, then diet history to rule out the malnutrition or A vitaminosis, etc., loss of weight, drugs and chronic alcoholism, etc. Now, in the next class onwards, we shall start with the approach to loss of appetite in the absence of the disorders that will deal through different case studies. Thank you very much.